When a hospice patient dies, there's a lot to process. Grief emotions, along with business decisions that need to be made. And today we're talking about what death events look like in hospice. You're listening to Heartbeat from the Heart of Hospice. I'm Jerry Fenter, here with Helen Bauer.
Whether you're a family caregiver or an end-of-life professional, we're here to enhance your hospice experience by connecting you with information you can use about end-of-life care. Because we know how busy life can get, Heartbeat is designed to give you helpful information in a bite-sized format.
So when people think of hospice, what's the first thing people think about?
Death, dying, angel of death,
Right.
morbid people.
Exactly. So that's the typical thoughts that most people have when they think about hospice. And in some ways, this is true because hospice deals with death on a regular basis.
Right. It is a huge part of what we do.
It is. Now, we're always going to say that hospice is not all about death. We're about life.
Right. It's about quality of life. And it's not about quantity. We're not looking at how much time we can give you. We're looking at how full we can help your life to be in the time that you have.
Right. So those of us who work in hospice actually do see a death event on a pretty regular basis.
We do.
Today, we wanted to talk with you about the death event and what it sometimes looks like and what it would hopefully look like for a patient and a family, and what the team does during a death event.
And we're not talking about the actual dying process today. That would be a podcast for another day. We're just talking about when the patient dies, what happens, who's there, and what caregivers, families can expect from the hospice team.
Right. So death is a common occurrence in hospice care. It's really what we do, and it's why we're here to do this.
True.
So the hospice team, all of us on the hospice team, are educated and skilled in facilitating what needs to be done and what can be a very difficult and often emotionally charged event. So the hospice team really does have that ability to be there to help during this very difficult time.
So we're going to start with the nurse. We're going to go through the different members of the interdisciplinary team and talk about what their roles would be and things that they might be doing at the time of a patient's death. So we'll start with the nurse. So the nurse a lot of times pronounces death. That's assessing the patient and giving a time for the time of death. Also providing education. Okay, so this is what has happened. This is where we are. This is what's going to need to happen, and I'm going to help you do it. That's the whole idea, is we're going to walk alongside you. Just because the patient has died doesn't mean the companioning that a hospice team does with the family is over with. Our job is not through. We're not just going to drop everything and leave you at that point. We're still with you. We help with post-mortem care sometimes to clean the body, get it ready for final disposition, wherever that may be. The nurse a lot of times will waste medications with the family or show them how to do it.
Okay, so describe what you mean by wasting medications.
So certain medications, opioids, narcotics, to make it easier, pain medications, sedatives, things like that, we want to destroy those because they're not supposed to be used by anyone else. The family owns them once the patient has died. The next of kin basically owns them. And the nurse gets permission from the family and can facilitate is the word I will use. The laws about that have changed in the last few years. It's been a little bit confused, a little bit confusing, but to prevent other people from using it and prevent diversion, we like our families to let us help them waste medications. And basically what we do is we put the medications into some sort of substance like used coffee grounds or kitty litter, things like that where the medications can't be extracted and taken.
Right. Okay. Thank you. I just want to make sure that people were very much aware of what it meant to waste medications. So the social worker role is someone who can be there or may not be there, but even prior to death, will do a lot of counseling to prepare for the death. They can do mediation to help if there's any kind of family conflict or family concern when it comes to what's happening with the patient. They can also provide guidance on funeral arrangements. And again, this may be something that's done prior to the death, or it may be something that needs to be done at the time of death. And so the social worker, again, may or may not be present at the time of death, but they are definitely there for the purpose of giving guidance when it comes to the death event.
A lot of times a nurse will be the first person. Well, actually, that's not true. I would say a lot of times an aide is the person who is there when the patient dies. They have the most frequent contact, the most frequent visits, most intimate contact, and a lot of times they are the interdisciplinary team member who's present when the patient dies. They get the nurse over there, and if there's a need, especially with funeral arrangements and any special counseling, then that nurse gets on the phone, talk to the social worker. I need some support out here, some additional support for the family. Additionally, if there's a large family, sometimes you need more than just a couple of interdisciplinary team members. It's all hands on deck. So you've got the nurse who's managing coordination with the funeral home, but you need the social worker there for family counseling. You need the chaplain there for bereavement needs. The aide is there for postmortem care. So you get the whole group involved.
That's right. So the chaplain, again, may or may not be there at the time of death, but they're there also in many cases to provide encouragement for the family, to provide that faith support, depending on what the family's faith needs are. Maybe help to coordinate rituals that are important for the family's belief system, to also coordinate with the patient's own clergy to make sure that they are there and present if the family wants them to be there. And then just to provide bereavement needs as well, to help with just the encouragement and support that a family may need, especially if there are children involved.
Well, so when you say rituals, what kind of rituals would you think about that might need to occur, that a family would want to happen after a patient dies?
So depending on the family's belief system, it might be that a patient would be dressed in a religious garment after death. It could be that the family would want to actually perform the postmortem care themselves because of their faith and belief rituals.
Maybe we need to define postmortem care.
Okay, that's true. I'll let you do that since that's more along your area.
Well, postmortem care can look a lot of different ways, but basically postmortem care is the care of the body after the death has occurred. So a lot of times it's just washing and cleaning, and then, of course, dressing if there's something special, or, depending on the disposition, the final disposition of the body, how they would be dressed. A lot of times a patient will go to a funeral home just in whatever they have been wearing. But if there's a religious garment that needs to be placed on there, and sometimes there are faith systems where the family wants to be responsible for the cleaning of the body, sometimes especially the female members of the family. It just depends, but you have to ask. And the nurse, the chaplain, the social worker, these are all questions that should be asked in advance, but they are very intimate, very highly emotional things to discuss. And it may be that there has not been time or an appropriate space to have that conversation before the death actually occurs.
This is true. And so anointing the body may be something that's a religious ritual that the family would like to have performed, and it may require the experience and help from the outside clergy.
Well, and aren't there certain rituals for instance, a Buddhist patient, and things that only a Buddhist monk can perform? So the spiritual counselor or the chaplain would coordinate with outside community clergy to make sure that those things happen appropriately. Yes,
that's true. And then the aide is also very involved in the death event. So she or he could perform postmortem care, and again, just supporting the family. We have said this many times before, and we'll continue to say this. The aide is the person who is probably most knowledgeable about the patient because they see that patient more than anyone else on the team.
which means they see the family more than anybody else on the team.
That's right.
And I think sometimes because the aide is not seen as a counselor, they're not doing a psychosocial assessment or a spiritual assessment, that just that casual conversation with the aide may reveal more feelings and dynamics in the household or the family than we realize. Let's face it, the aides are the backbone of the interdisciplinary team.
Definitely.
They truly are.
The last person that we want to mention are volunteers. The
Yes.
volunteers could be vigil volunteers who are actually sitting by the bedside, maybe with the family, or if there's no family, they may be the only one sitting there. So a volunteer may be there as a vigil volunteer. A volunteer may be there as a death doula even. An end-of-life doula who is providing care with the family. And so we don't want to forget about our volunteers either.
We wanted to take a moment to remind you that the mission of the Heart of Hospice is to be an advocate for quality end-of-life care. One way we do that is by providing education and consulting for hospice and palliative care professionals. The leadership of the Heart of Hospice has over 20 years of combined hospice experience. We can provide training for your interdisciplinary team through webinars and virtual events on topics such as self-care and grief management for professionals, diversity, competency, and healthy boundaries, or a topic of your choice. If you need a speaker for a leadership or community event, please contact us at host@theheartofhospice.com. Now back to today's episode. We always want to be realistic about how events in hospice look. Anybody who's been listening to the podcast has heard me say this. It is not touched by an angel. The white light's not going to shine down on Michael Landon. He's not going to be there. It's not like that. It's very different. But it can be complicated. Sometimes the death, even in hospice, is unexpected.
This is true.
Of all the words to use for a hospice death, sometimes it's not a drawn-out dying process. Patients have an acute event and are just found that way. It happens. But it can be overwhelming. And it's not just overwhelming for that family. It can also be overwhelming for the hospice team.
Okay, so describe why it might be overwhelming for a hospice team.
Well, for one thing, when we have families that have complicated grief, when they have young children, or there's a family member with mental illness or Alzheimer's and dementia issues or special needs, a mental disability, we have to deal with that. And it draws on every skill that we've got. Our clinicians, our spiritual, our psychosocial professionals. And when we do that from day to day, you may have one death that you're at right now, but it may be the fourth death you've been to in the last 2 weeks.
Right.
And maybe you've accumulated over the last 10 years of practice hundreds of death events that you've been to. And it is emotionally draining and mentally draining to provide care that way. It's a very intense immersion into a situation like that. Sometimes there's disagreement among family members, discord among family members, and that is a very difficult situation to mediate. And that's why I say, all hands on deck.
Absolutely.
Get everybody in there. Sometimes there's a lack of funeral planning. And again, maybe it's because they didn't want to talk about it for whatever reason, or maybe they didn't have time. But all of those things can add up to create challenging, overwhelming situations for the team members.
Very much so. So describe a death event that you were involved in. What was it like for you? Of course, you have been at many, I'm assuming.
Yes.
Was there one in particular that you felt like was particularly moving for you, that it was one of those situations where, everything seemed to go well?
I've had a lot of deaths that I was present for that were what we would have called good deaths. And it's a little bit upside down because hospice people will tell you that a good death is one where the patient doesn't struggle and the symptoms are managed and the patient's comfortable. But a good death is much more than that because the patient and the family get to decide what a good death is. A good death may be, I want to die in the hospital because I can't be in my home, or my spouse doesn't want me in the home when I die. Or I have small children, my grandchildren, my children are in the home. Or, I'm going to deliver a stillborn baby, and hospice needs to help manage that. A good death can look different ways. I've been blessed to be present for a lot of deaths that were at home. And it's hard to select one because so many of them were can you use the word good experiences? Meaningful experiences to me.
That's good. Yeah, that's a good way to describe it, I think.
But some of the most complicated situations I remember having when I was a field nurse was walking into a home when I was on call in the middle of the night and going into a home for a patient that I had never seen before. They had never met me, and there are 15 family members standing there of various ages and stages. You may have a spouse, adult children, grandchildren, people who turn up out of the woodwork who haven't been there in 3 years, but they've come to that death event at that particular time. And then I think you have to look at not just their relationships to the patient and how they're grieving, but what their roles have been. People who have been the decision makers who are no longer decision makers, or healthcare clinicians. We're some of the worst. We are some of the worst because we don't know how to let ourselves just be grievers, just be family. This is your dad. You're not his nurse. You're his daughter. So today I will be his nurse and you will be his daughter, and we will walk this together. I'll walk you through it. I had it sort of became a ritual for me. When I had a patient die, or I had a death that I went to, and it wouldn't matter whether I knew them or not, I had a way of touching them if it was appropriate when I was doing my assessment to assess whether they had stopped breathing and whether the heart had stopped beating. I always put my hand on their shoulder or on a hand, if that was, if I could reach, or on their forehead. And at first, I think back now and I realize I used to do that because I wanted the family to see this as a transition, that this just wasn't a piece of physical being that's all that's left, it's just done. But it was a transitional moment. It's a connection. This physical body is still there. The spirit of this patient is gone, but I respect the being of the person. This is your person. And I didn't have to know him to be respectful of that. So it was a way of recognizing their humanity. This is going to make me cry a little bit, I think. For patients that I had known for a very long time, and there were patients that I, had been seeing that I was close with to their families, that small ritual of holding a hand or touching a shoulder while I did the assessment to verify the signs of death, that was my way of saying goodbye. I never went to view a body and things like that. I did visitation, but that was never my thing. I wasn't included in those pieces. And that was my way of sending off, That was my way of saying Godspeed and just recognizing the fact that I was honored to be their care provider, to be part of this intense experience for them, and I think those were very small, momentary spaces in time that became very meaningful for me. Very meaningful for me. I mean, even after all these years, I haven't done bedside care in a long time.
Yeah, that's beautiful. And it's obvious that those events do stay with you.
Well, they do.
I
can recall faces.
Uh-huh.
Yeah. I don't remember all the names of the patients that I did that for, but I recall those events. I will never forget that. You accumulate those memories.
Right.
Yeah.
Right. I recall one death in particular where it was a young man in his 40s who had multiple complications, health complications. And the wife had called me and said, "Can you please come by? We think that he's close to death." And so I went, and the home was full of family. Aunts, uncles, in-laws, outlaws, everybody was there, it seemed like. And the patient was in a hospital bed in the living area. The wife was sitting on a stool next to him. And so I went in and kind of squatted down next to her, next to the bed, and was watching, her, watching him, occasionally looking at the family. And as I'm talking with her, I'm glancing at the patient occasionally and saw his breathing stop. And the wife looked at me and I looked at her, and I think we both knew the moment when it happened. And I was there as the only team member at that point and realized that I need to get the rest of the team here. This is going to be could be a very difficult situation. And so I called a nurse who thankfully was not very far away and got there very quickly and pronounced the patient's death. And thankfully, it was a very good experience. Again, I don't know. Can we use the word good for a situation like this? Meaningful experience. And I actually had contact with the wife. She would call me occasionally and say, "Thank you for what you did." It was a very, very, very meaningful experience. And so many of the death events they are meaningful experiences, not only for the family, but for the team. And the fact that the team is there means something very special to the family, that we are there to help them. So the death event obviously is one that's very meaningful, very moving for everyone, including the team. And so thank you for letting us share this with you. And we hope it helps to understand a little bit more about what the death event is all about, what happens, and what you can expect from the team as the patient moves closer to that time of death.
Thanks for listening to Heartbeat from the Heart of Hospice. I'm Helen Bauer with Jerry Venter. Because we know your hospice journey is 24/7, you can always find us at theheartofhospice.com. Subscribe to the podcast wherever you're listening and leave a rating or review on Apple Podcasts.
To connect with us, you can send us an email at host@theheartofhospice.com. And you can also find us on social media. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.